name is Gloria. She's female, 84 years old. She's a widow and died recently. Her residential address is the nursing home in Northcote. Her next of kin is James, who's currently in Queensland, and Riley, who's married and lives with her family. She rarely visits her mother, only at least twice a week. Gloria's past family history is her father died with heart disease, he was obese, mother died of old age. Gloria has past history of angina, currently taking medications of GTN, lipid-lowering agents, and beta blockers. She has no known allergies. Current condition is she is obese, has poor dietary intake, does not exercise regularly, is a smoker, has high cholesterol, and is hypertensive.
So the signs that Gloria is showing is that she's anxious and restless. She has dyspnea, tachypnea, pale face, nausea and vomiting, and pain. Whereas for the symptoms, she is having cold sweat, her energy becomes weak, she has low blood pressure, she has health palpitation, which is rapid pulse, and she has chest pain. She reports that she may feel chest pain on the left side, spreading to her left arm with a mixture of tingling and burning. She also reports pain in the stomach, right chest and back. And she has angina pectoris, which is cardiac pain resulting from myocardial ischemia.
So her pathophysiology, ischemic heart disease is a result of a coronary artery disease. It is a narrowing and hardening of the arteries that lead to an imbalance between the supply and demand of blood for cardiac muscles. From the pathophysiology of ischemic heart disease, ischemic heart disease could lead to angina, myocardial infarction, sudden cardiac death, and chronic heart failure. The common cause of ischemic heart disease is atherosclerosis. Atherosclerosis is the abnormal amount of accumulated lipid substance and fibrous tissue in the lining of the arterial blood vessels.
In normal coronary arteries, the lumen is large without any narrowing by atheromatous plaque. The muscular arterial wall is also at normal proportions. However, for patients with ischemic heart disease, there is a deposition of lipids within the arterial walls, which blocks and narrows the arterial lumen and reduces the blood flow to the myocardial. Ischemic heart disease is not that common in females than in males, but it prolongs more in females over the age of 65 and is one of the major causes of death in women over this age, referenced by Mass and Appelman in 2010. The overall risk of coronary artery disease, modifiable factors and non-modifiable. Modifiable factors include hypertension, smoking, elevated blood glucose levels, obesity, physical inactivity, and high blood cholesterol levels. Whereas non-modifiable includes family history of premature coronary artery disease, increasing age, gender, race and cultural background. Reference from Edwards 2011.
The process of forming ischemic heart disease is with atherosclerosis, which begins with an injury to the endothelial cell that lines the artery wall. The injury that could have caused those include smoking, hypertension, diabetes, increased levels of low-density protein cholesterols, and decreased levels of high-density lipoprotein cholesterols. Other causes are called novel risk factors, which are C-reactive proteins, increased serum fibrogen, insulin resistance, oxidative stress, infections, and periodontal disease. The injured epithelial cells become inflamed and cannot make the normal amount of antithrombotic and vasodilating substances, therefore causes the injured endothelium to lose its ability to prevent clotting and vasodilation. This results in platelets aggravating when atherobone A2 increases the release of serotonin and endorphin combines to cause vasodilation. This leads to decrease of blood in blood flow and ultimately ischemia. From Silos and Los Ganila 2014.
Adapted from Grundy et al. In 2005, the difference between a normal and dysfunctional state of a patient with ischemic heart disease and an individual which does not have includes the dysfunctional state, which is the criteria for diagnosis of metabolic disorder in women, which at least 3 of these must be present. First is waist circumference of over 35 inches, fasting triglyceride level of over 150 milligrams per dl, high density cholesterol levels below 50 mg per dl, hypertension, systolic BP of over 130 mmHg, and diastolic BP of over 85 mmHg, with the use of antihypertensives. Fasting blood glucose levels of over 110 milliliters per dl, and dyslipidemia of 1.7 millimoles per liter in LDL and below 1.1 millimoles per liter in HDL, and central obesity, waist circumference of over 88 cm in women. The normal state includes cardiac output of 5 liters per minute, ventricular contraction in each ventricle of 70 milliliters of blood, ejection fraction of 55 to 75%, cholesterol levels of below 5.5 millimoles per liter, and triglycerides of 0.3 to 2 millimoles per liter in women.
The potential complications of ischemic heart disease are angina pectoris from RX meds not dated, heart attacks, heart failure, and arrhythmia, abnormal heart rhythms. When coronary arteries narrow within the wall, the heart may not be receiving the significant amount of blood when the demands are high, especially during physical activities. This causes chest pains or shortness of breath. One factor that could increase the chances of heart attacks would be when there is a formation of blood clot due to the rupture of a cholesterol plate. The lack of blood flow to the heart damages the heart muscle. When the heart is not giving the adequate amount of blood, it could interfere with the heart's electrical impulses, causing abnormal heart rhythms.
Pharmacological interventions. The core drugs for stable angina could include beta blockers and nitrates. The aim of the drug therapy is to lower myocardial requirement of oxygen and increase blood supply in coronary arteries. However, the choice between the two drugs depends on the tolerance the patient has towards the drug and if any contraindications exclude the usage of it. To a patient with stable angina, a short-acting nitrate should be offered, and beta blockers can be also offered as a first-line treatment for the prevention of angina. Sharma and Henderson, 2013. Atenolol, beta blocker, indication and relation to condition. First-line therapy for angina. This drug blocks the beta-adrenal receptors, which in turn decreases the rate and contraction of the heart. Pharmacology, Monash University, 2016. Atenolol also depresses the rate of sinus node, forcing a slow conduction to intraventricular node. All of these functions help stabilize angina, decreasing the myocardial contractility, in turn decreasing the heart's requirement for oxygen. Atenolol is also used to treat hypertension due to the drug's ability to lessen the cardiac output and therefore the reduction of blood pressure. Pharmacology, Monash University, 2016. Contraindications, bronchospasm, which occurs due to the blockage of the beta-adrenergic receptors in the muscle cells of bronchi. This increases the resistance in the airways, therefore this medication may be unsuitable to asthmatic patients. Monthly Index of Medical Specialities, MIMS, 2016. Side effects, disturbances of the gastrointestinal tract, i.e. constipation or indigestion, fatigue or dizziness, and bronchospasm, as mentioned in Contraindications, MIMS, 2016. Safety and monitoring. Because atenolol decreases the contractility of myocardium, this may cause cardiac failure. In this scenario, atenolol will be used and replaced with ACE inhibitor. However, the patient is not showing signs of cardiac failure, MIMS 2016. Beta blockers should not be abruptly stopped, as this will increase the risk of myocardial infarction. The patient should be informed that the only way to cease therapy is to gradually reduce the dose. Pharmacology, Monash University, 2016. Glycerol trinitrate. Indication in relation to condition. Relieves angina by dilating systemic and coronary arteries and reducing systemic vascular resistance. Burns, Bedden, 2015. This allows for greater oxygen and blood flow to the heart, possibly reducing angina pain. MIMS, 2016. It also lessens venous heart return to the heart. Pharmacology, Monash University, 2016. Contraindications. GTN is not to be given to patients with trauma or hemorrhage to the head as it can increase cerebrospinal fluid pressure, MIMS 2016. Side effects: hypertension, which can cause ischemia of the cerebrum, headache, dizziness, nausea, vomiting, flushed in face, neck, tachycardia, temporary loss of consciousness, MIMS 2016. Monitoring: GTN should be taken as soon as the first sign of angina occurs. It is best to take this drug when sitting down. A tablet form of GTN should be placed under the tongue to dissolve. GTN is metabolized quickly and the relief of angina pain should be within 2 to 3 minutes. If the pain is not relieved in 10 minutes, a doctor should be called. MIMS 2016. Safety: the patient under the influence of GTN should not be allowed to drive or control machinery. MIMS 2016. Aspirin, antiplatelet. Function and indication: to reduce the risk of myocardial infarction, a low-dose aspirin could be administered to the patient. Alma and Henderson, 2013. Aspirin impedes platelet aggregation, which could potentially turn into a thrombus, which in turn could cause a myocardial infarction. Contraindication: asthma, severe renal impairment, third trimester of pregnancy, MIMS 2016. Side effects: gastrointestinal irritation and escalation in bleeding time, MIMS 2016. Monitoring safety: aspirin increases bleeding time. If any bleeding is to occur, it should be monitored. MIMS 2016. Aspirin should not be taken with warfarin. E-Pharmacology, Monash University, 2016.
Metoclopramide is an antiemetic. Indication and relation to condition. It's commonly used to treat nausea and vomiting. This medication used mostly for stomach and esophageal problems. Metoclopramide works by blocking a natural substance, dopamine. It speeds up stomach emptying and movement of the upper intestine. Tizani, 2010. Contraindications. Metoclopramide is contraindicated in patients with known sensitivity or intolerance to the drugs. It should not be used to epileptic or patient receiving other drugs which are likely to cause extrapyramidal reactions. Since the frequency and severity of seizures and extrapyramidal reactions may be increased. Side effects: drowsiness, dizziness, tiredness, trouble sleeping, agitation, headache, diarrhea may occur. Safety monitoring: this drug may make you dizzy or drowsy. Do not drive, use machinery, or do not activity that requires alertness until you are sure you can perform such activities safely. Limit alcohol beverage. Older adults may have more sensitivity to the effects of this drug, especially drowsiness can increase the risk of falling. The another drug is atorvastatin. It's a lipid-regulating drug. Indication and relation to the condition. Atorvastatin is a group of drugs called HMG-CoA reductase inhibitors or statins. Statins are particularly well suited for lowering LDLs. Atorvastatin reduces the level of bad cholesterol, low-density lipoprotein, and triglycerides in the blood, while increasing levels of good cholesterol. Atorvastatin is used to treat high cholesterol and to lower the risk of stroke, heart attack, and other heart complications in people with type 2 diabetics, coronary heart disease, or other risk factors. In addition to eating a proper diet such as low cholesterol diet also helps. Contraindications: this drug cannot be used with people who already have some liver disease, cholestasis, hepatic encephalopathy, hepatitis, and jaundice, unexplained elevations in AST or ALT levels. Atorvastatin may cause fetal harm by affecting serum, cholesterol, and triglycerides level, which are essential for fetal development. Side effects: some side effects: joint pain, diarrhea, constipation, abdominal pain, and headache. Safety monitoring: liver function tests should be performed before and after the therapy. Serum lipid concentration should be monitored regularly throughout the therapy. Advise patient to report any muscle pain, cramps, tenderness, or weakness. Other lifestyle changes that may help this medication works better. Another one more drug is laxatives. We can use this is whenever necessary when patient gets constipations because of all these drugs is a PRM. So for stable angina, nursing and in assessment, initially monitoring of vital signs, ECG rhythm and oxygen saturation, and assess the pain characteristics, nature and intensity, location and radiation of the chest pain, any shortness of breath, palpitation, cyanosis, and some blood specimens we specifically need CBC coagulation studies, cardiac markers, and myoglobin and troponin. Myoglobin blood tests may be used to detect muscle damage. Myoglobin is a small oxygen binding protein found in heart and skeletal muscle. Troponin test is used to determine if you have any heart attack or injury to the heart muscle. And past medical history or family history, and encourage patient to have complete rest. And medical management may include continuous oxygen therapy, aspirin, nitroglycerin or morphine to relieve the chest pain. Assess if patient is having any other chances of thrombolytic. And diagnostics workups are cardiac stress testing, cardiac catheterization.
Examinations would be a vital source for the nurses caring for Gloria about her current health. One examination could be the 12-lead electrocardiogram, which is ECG, as it detects and records the heart's electrical activity. Through this, the ECG can show us Gloria's heart rate and rhythm, and also record the strength and timing of the electrical signals as they pass through the heart. Hence, an ECG would allow us, who are in charge of Gloria, to be able to detect any heart damage as a result of the IHD, and to alert the doctor. We should also include to run blood tests on Gloria to monitor her abnormal levels of cholesterol, sugar, protein, and fat levels due to her ischemic heart disease. Through this, nurses will be able to evaluate and determine the effectiveness of other interventions that we have taken in attempt to reduce the abnormal levels. We should also check for anemia in Gloria, as it could either be a contributor or alternative cause to a chest pain, which is a result of imbalance of myocardial oxygen supply and demand, and hypoxemia, which is low oxygen levels in the blood. Another intervention we could undertake to relieve Gloria's onset of chest pain would be to administer oxygen therapy to Gloria, as it will increase the amount of oxygen delivered to her myocardium and decrease the chest pain. In Gloria's situation whereby she is not at risk of type 2 respiratory failure, her targeted oxygen levels would be between 94 to 98%. It is important for us caring for Gloria to refrain from giving her too much oxygen, as it could constrict her coronary arteries and cause hyperoxemia. And we could use a low-flow oxygen device such as nasal cannula or simple mask if she has injury near her nostrils.
Therapeutic communication, stress management. Therapeutic communication between nurse and patient is utmost importance, as Gloria levels of stress are high and should be lowered. The nurse can do this by empowering the patient to take care of their own illness and change their lifestyle. Harvey 2004. Gloria could be also experiencing the onset of angina due to the emotional stress arising from her husband's death. Mosul Regional 2008. Myocardial ischemia is the disproportion between oxygen demand and supply. Stress is an influential factor in angina, as it can increase heart rate, which yields the lack of oxygen, evoking the pain. Moser and Rigel 2008. In order to reduce such stress, the patient needs to acknowledge and accept the death of the spouse. This belief will lead to Gloria of her expectation and enable her to cope with the present reality. Mosul Regional 2008. Furthermore, a nurse could implement stress management techniques such as meditation or relaxation therapy combined with guided imagery. Meditation can help Gloria calm by focusing on a word or sound and allowing the mind to become tranquil. Moser and Riedel 2008. Relaxation therapy involves teaching the patient how to voluntarily release tension. This is done through the breathing from the abdomen, taking long deep breaths. This can be done along with visualization of a peaceful image and serene as suggested by the guided imagery therapy, Moser and Riedel 2008.
We should educate Gloria on the low-fat and low-cholesterol diet, taking some way to exercise without triggering symptoms, and being able to maintain these new lifestyle changes to reduce the length of her stay in the hospital, improve her functional status and health. By teaching Gloria these lifestyle changes, it will help her decrease her high cholesterol levels, help her lose weight, and reduce the risk of it occurring again. Throughout Gloria's stay in the hospital after discharge, her family and her will need to learn more about ischemic heart disease, the signs and symptoms that are involved in the condition, and what they'll do when Gloria is not feeling well. As Gloria's nurses, we should be making sure she's taking the right medications for the right reason. As a nurse, it is our duty to educate Gloria on what type of medication she is on, what each medication does, how it affects her, and when she should take them. Informing Gloria about her medications will reduce the chances of her taking the wrong things and making the condition worse, as teaching patients about medication is important in achieving positive health outcomes.